Hello, everyone. This is the lecture on the renal and urologic system. And the first few slides, it reviews covers the content as review on the anatomy and physiology, EMP, for the renal system. Just to the slide, which explains the sites of action in terms of different medications, which will have different the function or the site of action will be, for example, the loop diuretics like Lasix, which is furosemide, for example. It has an effect on the um, the side effect. I mean, the site of action will be on what is called the ascending loop of Renal. It's right here, loop diuretics, which is an example of that medication called furosemide, which is Lasix, very common and um, being heavily used, for lowering blood pressure, for pulmonary edema, and for CHF, heart failure, and other indications. So that's just an example of how different medications work at different sites of the renal system. Another medication called aldosterone, which is a potassium-sparing diuretic. It will retain more potassium, given here the key, which is this arrow represent reabsorption, the white arrow, which is secretion. So you can tell that the Lasix or furosemide patient will lose too much potassium, will be lost and secreted in the urine. But patients on aldosterone, they can retain some potassium back to be reabsorbed into the system, into the plasma, so they don't lose potassium. So we call the furosemide, it's loop diuretic. It's called or listed as the potassium losing, and then aldosterone is potassium sparing diuretic. So this is just an example of how different medications work at different sites of the renal system. Then here we have the obstruction in the urinary tract. So the obstruction of the urinary tract can result from different reasons or causes or etiologies. Strictures can result in obstruction, fibrous bonds or like fibroses, um, dysplasia, the stenosis due to a tumor, for example, the so the obstructive uropathy, which is the anatomic changes in the urinary tract or urinary system caused by obstruction. Now, the severity of an obstruction can be determined by the location of the lesion or the obstructive lesion, by the involvement of one or more um, uh, both upper urinary tracts. Is it just the upper and lower or both? And the blockage, how severe, in other words, that the completeness of the blockage. In addition to the duration, if the patient has blockage of the renal, let's say ureter, right or left or both for like, on an hour or two or a day. So it depends on the duration of the obstruction. So the severity also depends on the cause of the obstruction. Is it a lesion? Is it a stricture or fibrosis or fibrous bond? Um, so we have two different complications from the obstruction: hydroureter, and we have the hydronephrosis. The hydroureter, which is the obstruction within the ureter itself, and that will lead into the retention of urine behind bypassing that obstructive area, which could be also due to the calculi, which is a kidney stone. And then the hydronephrosis, which is when the obstruction affects the kidney so that the retention of the urine will be inside the kidney. So kidney stone obstructing the lower third of the ureter, which has resulted in a hydroureter, and then the kidney stone obstructing the pelvis of the kidney, so it resulted in a hydronephrosis. The other cause of the obstruction, which is kidney stones, or what is called the urolithiasis, or kidney stones. So the kidney stones, the calculi, or urolithiasis, or kidney calculi, or kidney stones, all the same, means kidney stones in the kidney or the renal system. So the risk factors for the stones to be developed and present in the renal system, there are too many factors, or I mean, like risk factors. The most common one is the fluid intake, which means the dehydration and the concentration of the urine results in kidney stones. But usually people or patients, they have tendency to develop the kidney stones. Their body has um, the tendency to develop the stone. So the seasonal, when it's seasonal factors, which means that more kidney stones, frequency of the kidney stones during the summertime than the wintertime, because of the the temperature, the dehydration, the fluid intake, and the fluid loss. Now, the kidney stones are classified according to the minerals comprising the stone. So the factors from the pathophysiological perspective, when we say factors influencing the kidney stone formation, the first one is the supersaturation of one or more salts. So the presence of the salt in higher concentration than the volume able to dissolve the salt. So too much salt in the urine could result in kidney stones. Concentration, which means supersaturation or high concentration of the salt in the urine. Precipitation of salt from liquid to solid um, to solid state. So which usually it's due to the temperature and the changes of the pH, the urine pH, the temperature of the urine, or the um, the pH of the urine, hyperacidity or hyperalkaline, either alteration of the pH of the urine could result in kidney stone. In addition to that, temperature. Um, so the stones, can comprise of calcium oxalate, which is the most common one. Most people with kidney stones, they develop this type of kidney stones, or they have this type, calcium oxalate. And we have the second one counts for about 12%, which is these true white stones, which is composed of three things, or three minerals: magnesium, ammonium, and phosphate. And then we have calcium phosphate, and then uric acid stones, and the cysteine stones. So as the nurses, one of the clinical implications to educate the patient to decrease the frequency of kidney stone incidence in patients with high tendency to develop the kidney stones is to, first of all, to the patient, they have to be informed of the type or the composition of their kidney stones. So they will be able, so as nurses, we can educate them about the type of food that they should eliminate in their diet so that they can prevent the development of the kidney stones. So patients with calcium oxalate in adult health too will go over the nursing interventions, how to educate the patients in terms of what specific type of food that will be high in calcium oxalate, so that patients with this type of kidney stones, they can eliminate that type of food from their diet. The manifestations patient develop what is called renal colic, which is severe pain of the flank area of the affected side. The treatment, fluids, first of all, we have to give high fluid intake to also, as we said, decrease the dietary intake of stone-forming substances. Depends on the composition of the kidney stone, and also sometimes we have to remove the stone, so stone removal to be removed surgically, sometimes non-invasive, sometimes minimally invasive, or like through the cystoscope. Sometimes they have to do, like, open incision and to do a major surgery to remove the kidney stone, especially when it's inside the kidney, and if that's a staghorn type of kidney stone. The most complicated type of kidney stone is called staghorn kidney stone. So one of the complications of the urolithiasis or nephrolithiasis or kidney stones is hydronephrosis. Remember that that's one of the major complications is called hydronephrosis, and that's when there's a complete obstruction of the urine to pass through the ureter to the bladder, and then the urine could be collected in the kidneys, and that could result in a severe damage to the kidney and kidney dysfunction, and could result also in acute kidney failure. The neurogenic bladder, it's a general term of bladder dysfunction, and usually is caused by the neurogenic disorders. The types of these dysfunctions, the neurologic dysfunctions, are related to the site in the nervous system that controls sensory and motor bladder function, and usually result in from the obstruction. And there are different types. This is the autonomic dysreflexia or hyperflexia is one type. And we covered this, the autonomic dysreflexia or areflexia or hyperflexia under the neurologic system. And this was one of the complications that could result or develop in patients with spinal cord injury in the thoracic above T6. So in which that, there are some factors that should be prevented in order, or at least identified in order to prevent this autonomic dysreflexia or hyperflexia. So the full bladder could result in this complication. Fecal impaction could result also in this autonomic dysreflexia. So because the injury interrupts the central nervous system control of sympathetic reflexes in the spinal cord, so severe hypertension, bradycardia, and sweating can be triggered by that over distension of the bladder. So we have to continue or to prevent to have the practice and to teach the patient about the straight cath, for example, to prevent the bladder distension, because that could trigger the autonomic dysreflexia, which would result in severe hypertension, elevation of blood pressure, bradycardia, and perspiration, profuse sweating due to the interrupted CNS, central nervous system control of the sympathetic reflexes in the spinal cord. Another one, or another type of lower urinary tract obstruction is due to what is called the neurogenic areflexic bladder, which is a failure of the bladder to to be emptied, which is failure to empty the urine from the bladder. So, which is also called flaccid neurogenic bladder. And that occurs when there is an injury to nerves and the micturition center of this of the sacral cord or peripheral nerves that supply the bladder. And causes of this neurogenic aflaxic bladder could result from trauma, tumors, congenital anomalies like spina bifida, or the meningomyelocele, which is one of the very common congenital anomalies like spina bifida and the meningomyelocele. The first case study, as you review the urinalysis UA or urinalysis of patient admitted to the hospital with urinary tract infection with a UTI, then you found these results: specific gravity for the urine, 1.03, color is dark amber, and then protein +2, blood trace, and then the BUN creatinine, but the BUN or blood urine nitrogen is 40, and then creatinine 1.2. Now, the first question is that how would you interpret the importance of the UA or what is called urinalysis? Now, the urinalysis is the most important first step in evaluating kidney function. So we have to evaluate the kidney function by requesting the urinalysis, or as we review the urinalysis results, when then we are reviewing the kidney function. So the specific gravity is the measure of the urine concentration, and the normal value is between 1.015 and 1.025. In this case, the elevated specific gravity demonstrate there is an increased concentration of the urine. So we should evaluate for signs of dehydration such as increased thirst, dry skin, dry mucous membranes, especially oral mucous membranes, increased pulse, tachycardia, decreased blood pressure, hypotension. The color of the urine is normally light yellow amber in color, and in this case, the dark amber color of the urine demonstrate concentration of the urine as well. Normally, there is no protein in the urine. Protein is a large molecule supposed to not leak through the glomeruli, so it should not be present in the urine. No protein normally should be present in the urine. So increased urine protein will occur when there is a disease, dysfunction of the glomerulus. The size of the protein molecule cannot be filtered through the membrane of the glomerulus. So in this case, there is a small amount of blood in the urine. So blood occurs with infection in the bladder or kidney. So there is the presence of blood indicates there is a UTI. So what's the importance of the BUN or BUN and creatinine? The BUN, which is blood urine nitrogen, it's filtered by the kidney, and normal filtration of the urea depends upon normal blood flow to the kidney and normal glomerular filtration rate, GFR. So the glomerular filtration rate indicates is another function or evaluation of the kidney function. So the normal BUN is 10 to 20. So in this case, the BUN or BUN is elevated, which is 40. It demonstrates that the patient has an increased BUN, which is consistent with the dehydration or indicates dehydration. The second blood test or value to evaluate the kidney function is the serum creatinine. And creatinine is formed from the breakdown of muscle. Normal creatinine level is 0.6 up to 1.2 or 0.7 up to 1.4. And the serum creatinine in this case is within high normal range, 1.2. It's borderline. Now, discuss one disease first that could elevate the BUN In this case, the increase in specific gravity, dark amber urine, and increased or elevated 1 up to 40, each of these results is associated with the dehydration or decreased blood volume. So the most common reason for increased BUN is decreased glomerular filtration, secondary to fluid loss. So in this case, the patient had urinary tract infection, UTI, which at times sometimes can cause nausea and vomiting as well, the UTI. So if the patient was unable to take fluids, then dehydration could have occurred and the lab data would be explained. The next slide or a case study, it's about the structure and function of the renal system. And also a patient with dehydration. So the first question in pronounced dehydration, hypotension can occur. How would this affect the glomerular filtration rate, the GFR of the kidney? And why actions by the juxtaglomerular apparatus would occur to restore the GFR? Now, the GFR, the glomerular filtration rate, would decrease with a decline in blood pressure. So the GFR would decrease with a decline in blood pressure. The juxtaglomerular apparatus participate in renal autoregulation, and when activated, it will increase the GFR. So the process involves the release of renin from the juxtaglomerular cells found in the efferent arteriole. The renin enters the bloodstream and converts inactive angiotensin to angiotensin 1. The angiotensin converting enzyme from the lungs convert the angiotensin 1 to angiotensin 2, a potent vasoconstrictor of the efferent arteriole that in turn increase the GFR. The angiotensin 2 also encourages sodium reabsorption, and that will result in an increased secretion of the aldosterone, and eventually the patient also will have high blood sodium content and high blood pressure. So that's also explains why patients with renal failure or renal dysfunction, they will develop a hypertension. Second is, what is the effect? So what is the effect aldosterone has on the distal convoluted tubule, and why would the actions of aldosterone can be useful to patient in this patient situation? So the aldosterone secretion causes sodium reabsorption and potassium secretion. So high aldosterone, sodium will be reabsorbed into the bloodstream and potassium will be excreted in the urine. The aldosterone released by the adrenal cortex is stimulated by the angiotensin 2, which is what we just discussed, which is earlier, which is the RAS system. Renin, angiotensin, aldosterone system, the RAS system. Question number 3, what does the specific gravity test measure? And if someone has tested the specific gravity for this patient, what might it indicate? Now, the specific gravity or the osmolarity of the urine determines the concentration of solute in the urine sample. It can therefore measure both hydration status of the patient, if the patient is well hydrated or dehydrated, and it will also evaluate the renal function. This patient's urine would be concentrated based on the results, and the specific gravity would be also high. So it could be like over 1.03 up to 1.04. And this would reflect a decrease in hydration and water conservation by the kidney. So these are the before. So we'll review also the GFR, the bun and creatinine in the upcoming slides, and the creatinine clearance and the normal values or ranges for the GFR and for the creatinine clearance. Now the UTI. So there are different types of UTI, urinary tract infection. The UTI can be classified as the upper UTI or lower UTI, and this figure or image it puts that it will identify or put the landmark for what is classified as the upper or lower versus lower UTI. So the and this is the next slide is the one type of the UTI or one of the disorders of or different disorders of under what is called UTI is the acute cystitis, which is the inflammation of the bladder. And patient would have this is very common, is that, when patients have the acute cystitis or the inflammation of the bladder, then they would have frequent urination, frequency, dysuria, urgency, and lower abdominal or suprapubic pain. Now, they would treat it with antimicrobial, antibiotic, fluid, increased fluid intake, and then avoid also bladder irritants and some urinary analgesics. The interstitial cystitis, which is the painful bladder syndrome or interstitial cystitis, it will include different also infections like non-bacterial infectious cystitis and non-infectious cystitis and other types. But the manifestations most common in women 20 to 30 years old, they feel the bladder fullness or they experience bladder fullness, frequency of urination, and small urine volume, and with chronic pelvic pain. Pyelonephritis. So pyelonephritis, which is the inflammation of the pelvis of the kidney. And these are the two main pre-existing factors, like the vesico-urethral reflex and the dysfunction of lower urinary tract infection. So the patient will have obstruction from the BPH, benign prostate hyperplasia, either due to strictures or urinary stones, or like an example of this would be like patients in the long-term facilities, like in nursing homes. They will develop this from the use of Foley catheter. That's the main cause for elderly in long-term facilities. It can be acute or chronic. Acute, the chronic, which is becomes like persistent or recurring episodes. Patient will have recurrence episodes of the pyelonephritis inflammatory incidents that will lead to the scar tissue. That's why it becomes chronic. The risk of chronic pyelonephritis increases individuals with renal infections and some type of obstructive pathologic condition. So pyelonephritis, because recurrence with the chronic type, recurrent episodes of pyelonephritis will lead to scar tissue, poorly functioning kidney, and chronic pyelonephritis. So when it becomes chronic. That's when there is scar tissue. There's also the acute may develop what is called pregnancy-induced physiologic changes in the renal system. That would sometimes, like pregnant women, they develop the acute pyelonephritis. That's from what is called pregnancy-induced physiologic changes in the renal system. The pathophysiology of pyelonephritis. acute now the glomerular disease or disorders, the glomerular disorders, they demonstrate a sudden or insidious onset. They will have increased blood pressure, edema, elevated bun, decreased GFR, the increased capillary permeability and loss of negative ionic charge. And that's would result in a significant loss of the protein in the urine and passage of plasma protein in the urine, which means patients' plasma protein will be decreased, which is called hypoalbuminemia. So so the loss of the protein in the urine will result in a hypoalbuminemia. It will encourage the plasma fluid to move into the interstitial space. So the loss of the protein in the urine from the plasma that will result in a decrease in caudate colloidal pressure. So the fluid will be shifted to the interstitial space. And when the fluid will leave the plasma blood to interstitial space, that is called edema. Glomerulonephritis, which is the inflammation of the glomerulus, that could result from different reasons. It's an autoimmune disease, first of all. The could result from drugs, toxins, vascular disorders, systemic disorders like or diseases like diabetes or lupus, systemic lupus erythematosus, or viral causes. The pathophysiology of the AGN or the acute glomerulonephritis is that because there is a anti-GBM glomerular basement membrane antibodies. So the antibodies will attack the basement membrane, and with the antigen, it will form what is called the complex. So the immune complex becomes deposited in the glomerular tissue, and that will trigger the inflammatory mediators, and then it will elicit the inflammatory response. The autoimmune disease is different from the pyelonephritis. Pyelonephritis could affect it's systemic. First of all, the pyelonephritis could result in systemic manifestations like fever. Glomerulonephritis or EGN, it is an autoimmune disease, so it would result or it involves the immune system, so it affect both kidneys equally. Pyelonephritis, it doesn't affect for most cases, for most scenarios, or most of the scenarios, you do not develop both kidneys are not affected equally. So in the GN or AGN, both kidneys will be affected equally. And that's one of the differences between the AGN and the pyelonephritis. So this is the mechanism of action or injury. There is the position of the antigen antibody complex that will elicit the immune response. Result in the injury to the kidney, and that will eventually result in a loss of protein. A large amount of protein will be lost in the urine. And that's when the patient develop the edema due to the decrease in caudate colloidal pressure. And patient will be presented as if they have acute nephrotic syndrome, or the AGN itself is called acute nephritic syndrome. But there is also another disease called nephrotic syndrome. So let's just finish the AGN first, and then we go to the nephrotic syndrome. The acute nephritis syndrome is the AGN. It's the same. It's the acute glomerulonephritis. So the patient will have edema, the hematuria, dysuria, oliguria, hypertension, fatigue, nausea, vomiting. The nephrotic syndrome the patient will have develop a significant loss of the protein in the urine over 3.5 grams per day. So associated with a hypoalbuminemia and hyperlipidemia. And frequently it's subsequent to nephrotic syndrome will result as a complication from the AGN, from the acute glomerulonephritis. The patient will have generalized edema, the urine will be like, foamy urine, hypertension, ascites from the loss of the protein and the shifting of the fluid to the interstitial space into the abdomen. Now, the renal functions, and we did went over the kidney functions earlier about the bun, about the creatinine, about the GFR. The renal function, we can have an acronym of the WEPIT acronym. So that's one of the acronyms you can review or to recall and to remember the kidney or renal functions by knowing that acronym. So a few slides talk about the renal perfusion or blood flow to in the kidneys, nephron function, and here's another discussion to clarify or explain the creatinine clearance. And so we can say that the creatinine clearance is equivalent to the GFR. So when creatinine clearance, it can be measured by collecting the urine for over 24 hours, and then we send it to the lab, and then we will wait for the results. The GFR, it's the urine chemistry, blood chemistry, that you can get the results within like 15, 20, maybe half an hour maximum about the GFR. So it's a blood test. The creatinine clearance is a urine test. We send to the urine in a jar and collected in over 24 hours, and then we send it to the lab. But these values, the creatinine clearance, and the GFR, they measure the same thing, pretty much the same thing, which is the filtration rate at the glomeruli. And this is the equation how you can measure the creatinine clearance. As we review the urinalysis, the UA of the urinalysis of the specimen, the results from the urinalysis coming back from the lab, as you review these results, you'll be focusing on two main things. As you review if there is sediments, if there is cast, if there is, and then the color, and then the white blood cells, RBCs, if there's protein, but also you'll focus on these two things, nitrite and leukocyte esterase. The presence of these two, either one or both of them, present in the urine, it can indicate or high likely can indicate the presence of bacteria, in other words, UTI. So UTI can be not determined, but at least we can say high likely that the urine is infected with bacteria, just from reviewing the urinalysis before looking at the or requesting the CNS, which is the culture and sensitivity, because that could take up to 3 days before to get the final results of the CNS, culture and sensitivity. But urinalysis of the urine, our urinalysis, the results of the UA can be received within a short period of time, maybe less an hour. You can get the results. Then the presence and the CNS, the isolation of any bacteria or microorganism, and the presence of more than 100,000 CFUs, according the CFUs per ml over 100,000, that indicates the infection or UTI. Now the GFR, the optimal value for the GFR is 125 mLs per minute, which means that's the filtration rate in the glomeruli And then through that filtrate, the final outcome would be the urine. So out of that 125, we will have only 1 ml of urine from the 125, and then the rest of that 125 mLs will be reabsorbed back to the bloodstream. So out of 125, that's the filtration rate, which is, in other words, we call it GFR, or you can call it also creatinine clearance. The ratio of the bun to the creatinine is 10 bun up to and to 1 creatinine. That's the ratio, 10 bun up to 1 creatinine. Now, the creatinine is more, so the highest determinant factor of the kidney function is the GFR, or creatinine clearance. Next to that, as a less valid, reliable measure, is the creatinine, but it's very strong determinant, in which that the creatinine is not affected by many factors like the bun. The bun, or BUN, is usually affected by many factors. It will fluctuate based on the fluid intake, based on the muscle or damage, or exercise, or protein intake, or urine production, or the rate of the urine production. So many factors could alter and change and affect the bun, but doesn't affect the creatinine. So the highest determinant of kidney function is the GFR, creatinine clearance. Second is creatinine, and the least is the bun, because the bun fluctuates based on the many factors. Most of these factors would be the protein intake, fluid intake, exercise, muscle wasting, or muscle destruction. Next slide, which is the acute renal failure. No terminology now, it's acute kidney injury, because the failure, when we say failure, means it's irreversible. But this, you can say acute kidney failure, renal failure, or kidney failure, or acute kidney injury. So it can be pre-renal, intra-renal, or post-renal. And pre-renal, it indicates there is a decreased perfusion, and that's why there is a pre-renal acute renal failure. So that's the most common cause of the acute renal failure, and usually caused by impaired renal perfusion or blood flow. And there is a decreased blood flow to the urine that will result in a dysfunction to the kidneys. Like patients who may become dehydrated, or develop hypovolemic shock, or heart failure, or so that decreased perfusion to the kidneys, or cardiogenic shock also, because that will result in decreased perfusion, blood flow to the kidney, so that will result in a pre-renal acute renal failure. The intra-renal, and that's when there is a problem inside the kidney. Like an example of this one would be the infections, medications, invading like tumors, like metastasis, obstruction of the renal blood flow, or the AGN, acute glomerulonephritis, post-renal, or post-acute, or post-renal acute renal failure. So the post-renal will result from like the bypassing the kidney. In other words, if there is a prostate hyperplasia, for example, prostate hyperplasia, that's an example of post-renal acute renal failure. If there is an obstruction due to the kidney stones, urolithiasis or kidney stones, then the ureter, right, or left ureter, so that's good also, or the bladder, that is would result in post-renal acute renal failure. Now, the chronic renal failure, it can be classified according to this classification system, RIFLE, as risk, injury, failure, loss, and then the last stage, which is the end-stage renal disease or kidney disease, ESRD or ESKD, which is irreversible stage. So the stages are in the end-stage renal disease. So the classification from the least to the highest in terms of severity of the failure, so risk, injury, failure, loss, and then the end-stage renal disease. The end-stage renal disease that when the GFR is less than 15, mLs per minute. And there is this classification is based on two main criteria: the GFR and the urine output. You don't have to know, these specific numbers, but at least just to know that the last stage is the end-stage renal disease, and that's when the GFR is extremely low. And the GFR, there's a cutoff number for the GFR as long as it's above 60 for even healthy. Healthy people in the lab would reflect the healthy or normal values for healthy people at any time when the GFR is over 60. But the below 60 is very dangerous because that could indicate a kidney dysfunction. So patients with end-stage renal disease, ESRD, they will have a GFR of 15 mLs per minute. Then azotemia, when I say azotemia, which means the buildup of nitrogen-based waste in the blood, severe or extremely high BUN, azotemia, the uremia, and that's when there is azotemia, which is extremely high BUN and waste products, and clinical symptoms. And uremic syndrome, which is the syndrome that incorporate all the signs and symptoms. You will see that these symptoms or manifestations in the multi-systems or different systems throughout the body in patients with chronic kidney disease. And we will review these manifestations in the upcoming few slides. So this slide explains the severity of the detrimental effect of kidney failure, because all the systems, so it results in multi-system problems or dysfunctions or manifestations. So the manifestations will encompass all the systems. So the patients will have problems with the acid-base balance. They have a problem with the metabolic changes. They will have problem with the sodium, potassium levels. They will have problems with acid-base balance, as I said, and then the metabolic acidosis. They will develop metabolic acidosis. Cardiac changes like hypertension, hyperlipidemia, heart failure, the uremic pericarditis, lots of problems. Too many complications or manifestations would result from the chronic kidney disease. So these slides explain the changes in the resultant manifestations of the kidney failure. So the sodium, for example, the sodium at early stage, there is a risk of hyponatremia due to the loss of urine, but the late stages or later stage, there will be a decreased urine production, which would result in hypernatremia. So that will lead to severe fluid and electrolyte imbalance, like sodium retention, hypertension, increased high blood pressure, edema, heart failure, and then potassium, they will have hyperkalemia. So patients with kidney failure or renal failure, they will have hyperkalemia. And these are the results or the causes of hyperkalemia in patients with kidney problems like chronic kidney disease or end-stage renal disease. External sources of the potassium could be from, they get it from the diet, from drugs, medications like potassium supplements, or IV medications, which like potassium supplement. So that's about why patients with end-stage renal disease or chronic kidney disease, they should be on a low sodium and low potassium diet. They will have calcium and phosphorus changes. In other words, that they will have hypocalcemia and hyperphosphatemia, low calcium and high phosphorus or phosphate. So the because the PTH hormone, the parathyroid hormone secretion, it will increase in production in response to the hypocalcemia, and that will result in a bone resorption, which means that the PTH hormone will pull the calcium from the bones. So that's why patients will have osteoporosis, and they have they will be, so patients with end-stage renal disease, they will be on on a diet to lower the potassium. So they should be in eliminate the diet that is high in potassium content, and they should be on a diet high in calcium, and they will also receive the calcium supplement as well. And once they increase the calcium, they can decrease the phosphate at the same time. Cardiac problems, we indicated or included some changes in pertains to the cardiac, like hypertension, hyperlipidemia, heart failure, left ventricular hypertrophy, cardiomyopathy, uremic pericarditis, cardiac dysrhythmias, and that cardiac dysrhythmias will be secondary to the hyperkalemia. And one of the major problems with CKD or end-stage renal disease, and that will be common in all patients with end-stage renal disease, will be anemic across the board. All of them will have anemia, severe anemia. And the severe anemia, these are some of the causes, but the main cause of the anemia, other than these three etiologies, is the kidney responsible for the production of the erythropoietin hormone, EPO. So because the EPO hormone is not adequately produced, or in patients with end-stage renal disease, ESRD, the kidney is completely failed, so cannot produce the EPO. The EPO, erythropoietin hormone, stimulate the bone marrow to produce the RBCs. That's why the patients with kidney failure, they would have severe anemia. They develop severe anemia in addition to the bleeding tendency, because that's due to the defect in the platelet function. And they will be prone to develop infections because of the suppressed immune system. GI changes also, in addition to the halitosis and stomatitis, also patients will have anorexia, nausea, vomiting, hiccups. That's due to the uremia. And peptic ulcer also is common as well. Constipation. Patients will have, due to the inactivity, ingestion of salts and calcium also, and the fluid restriction, because they will be on fluid restriction because the kidney failed. So they will be in fluid restriction and low sodium diet. Asterixis, which is the jerky muscle twitching and like flapping tremor. And that's very similar to the asterixis and flapping tremor, which is the jerky movement of the hands. And that's also common in patients with hepatic dysfunction, like liver cirrhosis. The musculoskeletal, we said osteoporosis and renal osteodystrophy, uremic red eyes, and that's from the crystallization of the calcium and phosphorus. The skin changes, integumentary system, which is the skin alterations, changes. One of the major ones is, other than the pruritus and the itching, is the uremic frost, which will result from the urea crystallize, in which that the urea crystallizes on the skin when the BUN is extremely high. It's not that common, it's a rare condition, but that's could result if the patient, refuse, or if they miss or withdrawn from hemodialysis, because these patients with end-stage renal disease, they will be on hemodialysis sessions 3 times a week. Each session is like 4 hours. So they have to commit to 12 hours a week for the hemodialysis to be transported to the hemodialysis center, back and forth 3 times. So that's sometimes overwhelming, and sometimes patients just become withdrawn from the whole process and decide not to go. So if they refuse or miss or withdrawn from the hemodialysis, they could develop this uremic frost. So the answer to this question is B, which is struvite. So calcium oxalate or calcium phosphate stones, they account for about 70 to 80% of the stones. Struvite stones account for about 15%. And we said that they are composed of magnesium, ammonium, and phosphate. The uric acid stones account for about 7% of stones. Less common stones are the cysteine stones, which account for about 1%. The second, next question, the answer is A, spinal cord injury. This patient's condition is neurogenic detrusor overactivity. The spinal cord injury contributes to uncontrolled or premature contractions of the detrusor muscle associated with a neurological disorder. So this can be also, if you recall from the nervous system, there is a disease called Guillain-Barré syndrome, GBS. That could be also a GBS, Guillain-Barré syndrome. Next question, the answer is A, B, C, and E. So all but D. The detrusor areflexia is a lower motor neuron disorder in which the detrusor muscle are not contractile. So the detrusor muscle, which is the muscle which compose the bladder, it's not contractile, relaxed, flaccid. So it will cause an underactive bladder syndrome. Underactive bladder syndrome. The all other choices cause urine flow obstructions. So next question, the answer is C, which is a group A streptococcus. And this is a very important question. You will see a very similar question in pathophysiology and in adult health, also 2 exams. The glomerulonephritis is an inflammation of the glomeruli and is often caused by a streptococcal infection. It usually occurs about 7 to 10 days after the infection. Next answer to the next question is A and C, pulmonary edema and metabolic acidosis. The pulmonary edema and metabolic acidosis can cause pulmonal respirations. Next case study, which is about UTI. So what other information should the nurse collect during the admission history? Now, in this case study, the patient is complaining of a syndrome that can be associated with either urinary or reproductive disease. The nurse should gather the information about the symptom, for example, how the burning started, how severe is the symptom, is it related to only to urination, or they are associated with symptoms like frequency, urgency, dysuria. So we have to ask questions about the past history of UTIs, urinary tract infections, if the patient had developed UTIs in the past. And number 2, what physical examination should the nurse complete during the initial exam? The nurse needs to examine the urine for color and appearance. She should do an examination of the abdomen to check for bowel sounds and the presence of mass or pain. Also to check the external genitalia, to check for anal lesions, redness, discharge. Now, what findings should the nurse expect on the urinalysis if this is a simple cystitis? If this is simple cystitis, the urine will often be a darker color and may have a presence of blood, which is hematuria. When we do a test called dipstick, which is urine test, that can be positive for the nitrites. So we said that two main things that could indicate the UTI: the presence of or positive result of nitrites and the leukocyte esterase. And these nitrites, which are formed when the gram-negative bacteria break down in the urine, so then we'll have nitrite. It can also have what is called leukocyte esterase, which is leukocyte esterase is the enzyme which is associated with the white blood cells and the urine. So the presence of these two components is indicative of the UTI, or which is in this case, which is the simple cystitis. Now the difference, and as we compare the number 4, which is comparison of the UTI urinary tract infections in peds versus geriatric population. And the peds and geriatric population, there can be an increased incidence with increased morbidity and mortality, both of them. The incidence of the UTIs is increased in young females due to the straight and short urethra, which will enhance the ability of the bacteria to enter the bladder. Frequent infections are associated with chronic kidney changes, or they need to be prevented. And I mean, so these infections has to be prevented. In the geriatric population, two main factors that need to be addressed. So in younger population or in peds, so that's the hygiene that should be addressed. But in the geriatric population, two main factors should be addressed. Most mainly should be the fluid intake. So there's an increased incidence of asymptomatic bacteriuria, which is asymptomatic UTI. In other words, especially in women, in other words, that the elderly, they will develop the UTI, and the only manifestation would be just the confusion. So the bacteria in the urine do not cause symptoms like in peds and in adult or an adult population. So assessment, we should be careful as we assess the geriatric, because they do not tend to develop the classic signs of UTI, other than most of the time just be confused. Urolithiasis, which is kidney stones, and this is an example of a case study on urolithiasis, which is kidney stones or renal stones. So the first question, at the hospital, an abdominal radiograph showed the presence of renal calculi in the patient's ureter. So the mechanism outlined the mechanism of stone formation in the kidney and the role of the citrate in the kidney. Now, the formation of the renal calculi relies on, as we said, supersaturation of the urine, which is hyperosmolarity of the urine, becomes more concentrated. So the calculi are formed from the crystals, particular crystals that are not unbound and highly concentrated in the urine. And these components will aggregate around small nucleus of organic or inorganic material. So I'm not going into too much details about this, but at least just to know that the formation of the kidney stones would result due to the hyperosmolarity or the concentration or the supersaturation of the urine. Either that's calcium oxalate or calcium phosphate or uric acid or cysteine, but that's one of the major reasons. And usually patients, when they become dehydrated, then they develop the kidney stones. But at least to say that the patient, their body has a tendency to develop the kidney stones, familial, genetic, but there is a tendency to develop kidney stones. Now, why would the administration of calcium supplements be useful for a patient with calcium oxalate stones? Now, calcium supplementation encourages the binding of oxalate calcium in the GI tract. The calcium supplement will encourage and promote the binding of the oxalate to calcium in the GI tract. The oxalate fails to be absorbed in the bloodstream and then subsequently excreted. And the third question is about the hydronephrosis, can be a complication of renal calculi or kidney stones. So as we said that the hydronephrosis occurs when an obstruction causes the urine to accumulate in the ureter, or the hydronephrosis here is in the bladder. So the hydronephrosis will develop when the obstruction causes the urine to accumulate in the kidneys, which is the pelvis, and the calyces or the parenchymal cells of the kidney itself. So the back pressure occurs in the kidneys when the GFR, or the glomerular filtration, is still occurring despite the previous changes. So the nephrons will suffer the mechanical damage from that increased pressure. In other words, that the increased volume of the urine retained in the pelvis and the kidneys will increase pressure against these nephrons, and eventually could result in a decreased or alteration or decreased blood flow to the kidneys, and the will eventually lead to renal failure. Acute renal failure, chronic kidney disease. The first question, what type of renal failure is most often seen with dehydration? So the pre-renal failure is defined as decrease in renal function that is caused by a condition outside of the kidney itself. And we said an example of that: decreased perfusion, hypovolemia, decreased cardiac output, decreased in heart failure, decrease in hypovolemic shock, cardiogenic shock. So that's pre-renal failure. In the case of dehydration, the patient's kidneys are unable to perform their normal function, or that which is the filtration of and the normal functions that we discussed earlier. So the kidney in the pre-renal failure is not damaged. The decrease in the blood volume will decrease filtration and cause abnormal kidney function tests. So the results of the kidney renal function test will be abnormal, but there is no actual damage to the kidney. So it's a prerenal failure. So that's because it's consistent with that dehydration and the fluid, blood flow to the kidneys. That's why there is a prerenal acute renal failure. So what signs and symptoms noted by the nurse are characteristic of renal failure? Now, in this case scenario, the clinical manifestations of the client are a history of vomiting with a decreased intake of food and fluids. Also, the patient is taking or is on a diuretic, which will increase sodium and water loss. The physical examination demonstrated also a dry skin, decreased turgor, skin turgor, and dry oral mucous membranes. The vital signs also is consistent with decreased blood volume, which is usually it's a hypotension and a tachycardia. So the increased heart rate, of course, to attempt to maintain cardiac output. That's why there is a tachycardia. Compensation to an attempt to maintain a cardiac output when the blood pressure or blood volume is decreased. The urine specific gravity would be high, and the kidney is retaining fluid in the presence of decreased blood volume. So if the blood pressure continued to drop in the patient and the patient developed acute tubular necrosis, ATN, what would happen to the kidneys tubule? The normal functions of the kidney tubules, reabsorption of electrolytes, maintenance of acid-base balance, and concentration of urine. All of these functions will be impaired. So the acute tubular necrosis is caused by ischemic changes within the kidney tubules. There's decreased perfusion, ischemic changes. So over time, decreased blood volume can decrease fluid or blood flow and result in ischemic changes. So if the kidney tubules is damaged by ischemia, then the kidney will no longer be able to function effectively to concentrate the urine. And we reviewed some of the functions or normal functions of the kidney tubules, like reabsorption of electrolytes, maintenance of acid-base balance, and concentration of the urine. All of these will be impaired. And number 4, so it's just because number 4 is interventions. For each phase, this is can be discussed in adult health too. So I'm going to skip that question because that's nursing care of patients with kidney failure. End-stage renal disease. So the first question is to compare and contrast the azotemia and uremia. And I did define that earlier in one of the slides, the difference between azotemia and uremia. And both of them, uremia and azotemia, they describe the accumulation of the metabolite wastes, which is mostly it's the blood urea nitrogen, which are usually excreted in the urine. So these are going to be retained in the blood, and that's why the patient become azotemic and uremic. So the azotemia, which is the presence of the nitrogen waste products like urea, uric acid, creatinine, that will retain in the blood and not being excreted because of the kidney failure. And patient is often asymptomatic when there is azotemia. But uremic or the uremia that results from the presence of all these products when it's accumulated in the blood, and that will result in plus patient is symptomatic. Symptomatic in terms of that the patient will be, develop like nausea, vomiting, sometimes even result in a coma and death. So that's the difference between azotemia and uremia. So 2 years ago, the patient's physician told him to decrease the protein intake, despite the order that or despite what she ordered. Well, um, or the patient could not stop having chicken, beef, pork, or eggs. So why did the physician warn the patient about this specific diet? Now, in renal insufficiency, the kidneys have difficulty secreting the waste products of protein metabolism. So the waste product of the protein metabolism will be retained in the blood, in the plasma, and able to be excreted by failed kidneys. So a low protein diet during this time can slow the progression of the renal failure and decrease the symptoms of uremia. So that's the main reason for the low protein diet in this patient. Now, patients' feelings of weakness and fatigue are symptoms of uremia. And why he's anemic? We explained that earlier because the erythropoietin. Erythropoietin hormone produced from the kidneys stimulate the bone marrow to produce the RBCs. And that's why a patient is severely anemic. So knowing what you do about patient's history, why is the LV or left ventricular dysfunction a concern for the physician? Now, hypertension increases the workload on the left ventricle, and it will increase oxygen demand. Anemia contributes to left ventricular hypertrophy and ischemic events. So these are all factors in patient's history that predispose him to LV or left ventricular dysfunction or congestive heart failure. And I'm going to skip the last two case studies. They are not required in terms of content for pathophysiology, because these two, these cases on the incontinence is extensively, I believe, that covered in Adult Health 1 and different types of incontinence. So that will be the end of the session for renal failure. Renal system.